thank you, everybody, for being here today. We're very honored to have Professor James Chalmers with us, giving us updates from two workshops that just recently happened over in Europe. I am joined today by Amy Leitman, President of NTM Info and Research. So if you are not familiar with Running on Air, I am the president, Mary Kitlowski. I am the president and founder of Running on Air. And there we go. So we do a lot of work most recently around supplemental oxygen, but also big advocacy work with bronchiectasis. You can follow us on social media, and you can see our various social media accounts over there on the right. One of the big things we put out a couple times a year, and you're getting the first glimpse of our modified portable oxygen concentrator comparison chart. We are adding more info about batteries for POCs. And if you're on supplemental oxygen or know someone who is, please check out our comparison chart before purchasing one. And you have a QR code and our website over here to the right. So again, Amy and I will be moderating today.
Thank you, Mary. It's nice to be here. My name is Amy Leitman. I'm the president of NTM Info and Research. We are a patient advocacy group for non-tuberculous mycobacterial disease and related comorbidities, including bronchiectasis. Our organization was founded by a patient and her husband to provide support and education for patients. We run a wide network of support groups, both in person and online. We also have a robust patient forum that people can join. We have a full webinar library on our YouTube channel, and we also have a really great informational pamphlet on NTM called Insight: A Patient's Perspective that people can order free of charge. I'd also like to let you know that we do hold an annual patient education conference for NTM and bronchiectasis. This year, we will be holding our conference May 14th and 15th at the Claremont in Berkeley, California. There is also a virtual option, so you can log on to our website, ntminfo.org, for more information and registration information as well. Thank you.
Thank you, Amy. And we would also like to thank Insmed, who is supporting this event today. So just a few housekeeping things. Just want to let everybody know we are recording, and the recording will be made available probably not until close to the end of March. And as soon as it is available and is online, I will email the recording out to everybody. And for today's session, we ask that you put any questions that you have into the Q&A. So I have the honor of introducing Professor Chalmers. He's a professor. Professor Chalmers is the Asthma and Lung UK Chair of Respiratory Research at the University of Dundee and a Consultant Respiratory Physician at Ninewells Hospital in Dundee. His main clinical interests are in difficult lung infections and particularly bronchiectasis. He runs a research group focused on developing new treatments for bronchiectasis and related conditions. He chairs the European Bronchiectasis Registry and is current chair of the European Respiratory Society Bronchiectasis Clinical Practice Guideline Panel. He is current chief editor of the European Respiratory Journal. And all around great guy who I don't think ever sleeps. Thank you, Professor Chalmers.
That's really a lovely introduction, and thank you very much, Mary and Amy, for everything that you're doing for patients with this disease. We're seeing big changes in bronchiectasis, and a lot of the reason why care is getting better is because of patient power and patient empowerment, and you've both played a really important role in that. I'm not allowed to put on my camera at the moment, Mary. I don't know if that's a problem, but I'll start speaking, but you won't be able to hear me for the time being. I was going to start off just by saying I've been having some computer problems today, so I've warned Mary. Hopefully we'll have no problems during this presentation, but if I disappear for a moment, it's because my computer's restarted itself. I'll be back within 90 seconds, hopefully. But let's, fingers crossed, we'll get through this presentation without any problems. We've got a 90-minute session today, so what I'm going to do is take you through some latest updates in bronchiectasis research from these two meetings. Real big thank you to Mary for giving us the opportunity to highlight some of the research that's coming out. But the Q&A session is really important, and I'm very happy to take questions about anything related to bronchiectasis and NTM, not just related to the research that I'm going to show you. So these are updates from the Respiratory Tract Infection Forum and eBrow, two conferences that have just taken place in Europe. First, very important, my disclosures. Today's session has been sponsored by Insmed. As Mary said, I work quite closely with them and other pharmaceutical companies because we really need to work with companies in order to get new medications through for patients with bronchiectasis and NTM. So I think that's a good thing, but take that into consideration when I present data related to those companies. So the two conferences that we've just had in Europe at the beginning of February and then mid-February are the Respiratory Tract, firstly, the Respiratory Tract Infection Forum. This one was held in Glasgow. And this is not just focused on bronchiectasis, but it's very much focused on infection. And so in the first part of this presentation, I'll talk a lot about respiratory infections in people with bronchiectasis, because the focus of this was really on antibiotics and alternatives to antibiotics for respiratory infections. As an aside, one of the things I love about this conference is that it's held on an IMAX screen, so probably the biggest screen, as you can see on the right-hand side, that I've ever presented on. Amazing opportunity to see things in very high detail. It's a cinema, so you sort of feel like watching a movie halfway through the conference, but don't worry, we didn't. And the second conference, which we've just really got back from a few days ago, was held in Paris, was the European Bronchiectasis Workshop. And this is similar to the World Bronchiectasis Conference. It brings together all of the experts in Europe with bronchiectasis, and we were delighted also to be joined by US experts like Chuck Daly from National Jewish to talk about different aspects related to bronchiectasis. So those are the two meetings, and I'll give you some tasters of what was discussed at those meetings. So I've picked out a few things from 6 days of scientific presentations. The first one was around new treatments for Pseudomonas infection. As I mentioned, the Respiratory Tract Infection Forum is very focused on infections, and so Pseudomonas came up repeatedly. And there's some interesting new data there, some views to the future of where we might be going with Pseudomonas infection. I'm then going to talk about new anti-inflammatory treatments, because the new anti-inflammatory drugs dominated the discussion at the Paris meeting, the European Bronchiectasis Workshop, and there's some new very interesting data there as well. And then the other thing that I thought was really nice in the Paris meeting was at the end of the meeting, we had a round table with patient groups and patient advocacy organizations about what treatment for people with bronchiectasis should look like in the future. And so I'll touch on that a little bit at the end, because I think that's interesting and important. So let's start off with infection, which is a core part of living with bronchiectasis. If you, as a patient, send a sputum sample to the laboratory, it'll be positive in about 70% of cases. And the image on the right-hand side here is a Petri dish with some bacteria growing. This is what, after the sputum's been incubated and grown, this is what grows in the dish and can be identified as the bacteria. And the most common bacteria are two: Pseudomonas aeruginosa and Haemophilus influenzae. And Pseudomonas affects about 25% of people with bronchiectasis. And so it's a very important bacteria. And I know lots of the people on the call today are patients. So about a quarter of patients will have this bacterial infection. The other bacteria, things like Haemophilus, are also very common, and Staph aureus and so on. And Pseudomonas is really important because people who have Pseudomonas don't do as well as people that don't have Pseudomonas. So in sequence, people who've got Pseudomonas tend to have worse looking X-rays, more cystic bronchiectasis, which is where the airways have gotten very big. Lung function tests like spirometry, which many of you will do regularly, is lower when you've got Pseudomonas, and it tends to make the lung function go down faster. Hospital admission is sometimes needed for Pseudomonas because you need intravenous antibiotics when it becomes resistant to oral antibiotics like ciprofloxacin, and it causes a lot of inflammation, which means patients cough and bring up a lot of sputum. So all around, Pseudomonas is a bad guy, and something that we want to do something about. I thought it'd be nice to put this into some kind of context. And so when I gave a talk about Pseudomonas at this lung meeting, I described a patient of mine who's got Pseudomonas. So this is a typical, I would say, patient who's struggling with this infection. A 68-year-old lady who's got bronchiectasis. In this case, the patient has ulcerative colitis. That's a common comorbidity of bronchiectasis. Ex-smoker, has taken a long-term azithromycin, which is a long-term antibiotic that we use to try and cut exacerbations, and is also taking inhalers. That's what ICS LABA-LAMA means. It's a combination inhaler. And the coughing and bringing up phlegm is getting worse over the last 2 years. And they've now grown Pseudomonas for the first time. And they've been hospitalized twice because of severe chest infections. So the question is, what am I going to do? What options do we have for treatment at the moment for Pseudomonas infection? Well, the first line treatment in Europe, and I think in some places in the United States, would be to give an oral antibiotic for a couple of weeks to see if we could get the Pseudomonas under control, and then consider whether we would give an inhaled antibiotic to try to eradicate or clear the Pseudomonas, or at least control it. So this is what happened with this lady. So we gave intravenous antibiotics and an inhaled antibiotic called colistin. Unfortunately, the Pseudomonas stuck around despite the antibiotic treatment. Patient felt better, but it didn't get rid of the Pseudomonas. And that happens in about half of cases. So we gave the inhaled colistin long term, but actually after a while, the patient felt that their chest became tight, and so they wanted to try something else. We tried tobramycin, which is another inhaled antibiotic, and that also made the chest tight, unfortunately. So we tried another antibiotic, which is sometimes better tolerated, and they did manage to take that one, but still felt that they had a lot of symptoms and were struggling with that treatment. And eventually we got the disease under control by giving several courses of intravenous antibiotics to knock down the number of bugs, but it really took a long time to get stability for this lady because Pseudomonas is such a difficult bug. So this highlights that there are still, unfortunately, patients who struggle a lot with Pseudomonas. It causes a lot of cough and sputum, and it causes a lot of exacerbations or chest infections. And it highlights that our treatments work for many people, but they don't work for everybody. Inhaled antibiotics were discussed a lot during these conferences, and they're an important part of what we do for patients. They deliver much higher concentrations of antibiotic to the lung than we can get through injections or through tablets. And the idea is that they would have less side effects because they give less antibiotic into the rest of the body. So they deliver the antibiotics to where the infection is, and therefore where the antibiotics need to be. The problem, of course, is that the lungs don't like things being put into them. And so the most common problem, as happened with Our Lady, is that people feel that it makes them cough or makes the chest tight. And that happens in maybe 1 in 10 to 1 in 5 people who take these medicines. So they work, but they're not perfect. We presented data at the conference about how well they work. So they reduce exacerbations by about 20%. All the data is on the left-hand side here, but you don't need to look at that in too much detail. Essentially, the medication works if this line is to the left of the center line. That means that that in trials where one group gets the antibiotic and one group doesn't get the antibiotic, the group that are getting the antibiotic feel that they're getting a benefit. And in most cases, in most trials, that's the case. So it's on average, about a 20% reduction in exacerbations. It's a bit inconsistent between trials, but overall there's clear evidence that this approach does work. And that's why our guidelines say to try an inhaled antibiotic for people with Pseudomonas. They seem to work very well for people who are being hospitalized or needing a lot of intravenous antibiotics. When we looked at that data, there's a 50% reduction or a 52% reduction in the need for hospitalization in people who've got Pseudomonas who get a course of inhaled antibiotics. So that's really good, and means that we should probably be using them more in that group. The other thing that we've noticed that we've managed to now show in the research is that antibiotics also improve quality of life. So there's 2 quality of life questionnaires. We don't need to go into too much detail of those 2 questionnaires, but both of them show an effect in 11 and 10 randomized controlled trials, respectively, meaning that they make patients feel a little bit better. And I say a little bit because the magnitude of these score changes is not very, very high. But the message is that if you've got Pseudomonas infection, taking the inhaled antibiotic, we've now been able to show with various bits of research, reduces the risk of chest infections, reduces the risk of being admitted to hospital, and also makes patients feel a little bit better. But they're by no means perfect, and that's one of the challenges. So thinking about what we do at the moment, our guidelines are the eradication treatment, the inhaled antibiotics, and the long-term azithromycin for people where it's appropriate, people that don't have NTM. And so we've been thinking a lot to the future about how we could treat Pseudomonas infections better in the future. So now I'm going to show you a little bit of research. So 2 sets of research studies looking at potential new therapies for people with Pseudomonas. And these are all data that were shared at these conferences. So the first one that we're going to talk about is phages. Many of you will have heard of phages. These are little viruses. So this is a phage here, but they're viruses that infect bacteria rather than viruses that infect people. And so they're in a constant battle throughout the world, viruses versus bacteria. And the viruses kill the bacteria, and the bacteria try to adapt to survive against these phages. So the idea of phage therapy, so using phages as a treatment, is that we can find phages that are very effective against bacteria, isolate those, and then give them to a patient, either through the lung or through a drip into the body, and that those phages could then kill the bacteria for us, working a bit like an antibiotic. But because they're not an antibiotic, they will also work against antibiotic-resistant bugs. And there have been some fantastic case reports from the United States, particularly showing phages that have been able to get rid of NTM, phages that have been able to clear Pseudomonas. However, case reports, one-off reports, are sometimes a little bit biased. We tend to report the ones that work well and not the ones that don't work well. And so it's important that we get trials of phages. So this is how phages work. They attach to the bacteria, they go inside the bacteria, they hijack the bacteria to make more phages. The bacteria gets killed, more viruses come out, and they infect more bacteria, creating a cycle that means that you can kill lots and lots of bacteria. Lovely. So data that was presented at the 2 conferences shows the effect of phage treatment in people with bronchiectasis. This is data that's hot off the press. It's only part of a press release, so we always treat it with a little bit of caution, but it was discussed a lot at the conferences, so I think is nice to show here. And this is the data from the publicly available press release. So this is a phage preparation that's given by a nebulizer, so it's inhaled like an inhaled antibiotic. And in this trial, it was given to patients for 10 days. Patients either got phage or they got placebo. And there were 2 groups, one where they were taking phage on its own and one where they were taking phage with other chronic antibiotics to see if it adds on to what we currently use for people with Pseudomonas. And you can see there, patients were followed up beyond the 10 days that the medication was given for. And on the left-hand side, you can see that there wasn't a big difference between the groups on the primary outcome. So there's small numbers of people, 18 and 12 in the patients that didn't take regular antibiotics. And the phage group has a lower level of Pseudomonas. This is level of Pseudomonas here. And likewise, in the people who were on an antibiotic, the phage group were a bit lower. So you might look at that and say, well, maybe phages don't work. But if you look at the time course on the right-hand side, it looks like phages do work. So at baseline, you can see here, this is the amount of Pseudomonas. My red cursor hopefully shows up for you. And it starts to go down, but by day 10, it's not down all the way. It actually goes down further. It's still working after the medication's been stopped after 10 days. And it stays down after the period that the patients have been treated. It's having what looks like a bit of a long-term effect. Whereas in the placebo group, the people that didn't get phage, it's consistent all the time. It is killing the Pseudomonas. It's not killing it to the point at which it's been completely eradicated, but maybe we wouldn't expect that. Maybe that's a bit too much to hope for, but it does look like it's having an effect. And what we don't know from what's been released so far is whether that comes along with patients feeling better, having less exacerbations, etc. So I would characterize this as some encouraging data for phage. And phage would be a nice thing to have available for people with Pseudomonas because, as I said, it works against strains that are resistant, and it's not an antibiotic, so it's not going to kill off other bacteria apart from the Pseudomonas. So hoping this goes forward into another trial. The second thing I'm going to talk to you about is antibody therapy. And this is something that's becoming exciting. Antibodies are something your body naturally makes. So you make antibodies against viruses and bacteria when you get an infection. Many of you will have seen this before, the Y shape of the antibody. And the cartoon on the right-hand side shows how when antibodies recognize something that they're supposed to bind to, in this case, a bacteria, they stick to them, and that helps the immune system to clear off the infection. So that's what they're meant to do. And so so antibodies are part of the immune system to get rid of threats. For whatever reason, they don't work in people with bronchiectasis against bugs like Pseudomonas. But antibody treatments are becoming more and more popular in lung conditions and in inflammatory conditions. We use antibody treatments now against rheumatoid arthritis, against severe asthma, in cancer, and in COVID. So it's not unreasonable to think we could have an antibody treatment also for bronchiectasis. So this is how it works. An antibody is a Y-shaped structure. It sticks onto the bacteria, and then along come cells from your immune system, that, and particularly neutrophils, and they gobble up the bacteria because the antibodies help them to recognize it. We know that people who've got bronchiectasis already have antibodies against Pseudomonas, and they do. They've got high levels of antibodies against Pseudomonas. Both people who do and don't have Pseudomonas infection will have some antibodies. But these antibodies aren't the right ones. They don't work against the bacteria that we're infected with. So I'm going to show you some results of some research now where we've tested this antibody using people with bronchiectasis. So with AstraZeneca, we've been working on an antibody that binds against Pseudomonas. So it helps to block Pseudomonas from attaching to the lung. Obviously, if it can't attach, it will float off and disappear. It also means that the Pseudomonas can't kill the cells in the lung, and so it can't cause as much damage. And the other thing that an antibody helps to do, apart from blocking the virulence of the bacteria, is that it allows these immune cells to recognize the bacteria and get rid of it. So when we tested this antibody, we looked at whether patient cells could eat bacteria better because of the antibody, and you can see the bars here with and without the antibody. With the antibody, the cells are much better able to gobble up the Pseudomonas, so that's really good. So more antibody means more bacteria were eaten, and the neutrophils were therefore able to kill off the Pseudomonas. An important thing about any antibody treatment is that everybody's Pseudomonas is slightly different. And so we need to also know that this antibody is going to work against different people. So we took 100 strains of Pseudomonas from all over the world, checked by sequencing that the antibody targets were still there. And 73 out of 100 had the first target of the antibody, and 99 out of 100 had the second target, meaning that almost every single person would have at least one target, meaning that virtually everybody would be eligible for the antibody treatment if it became a treatment for Pseudomonas in bronchiectasis. So that's all great, but obviously patients want to know that it makes you feel better and stops exacerbations, not just that that it works in the lab. And so we've recently completed a randomized study of this antibody in people with bronchiectasis. We got the results a few weeks ago. We didn't announce them at this conference because we're going to be giving the results at the ATS conference in May. But this is very exciting because with phage and now with the antibody treatments, there's the potential to treat in future Pseudomonas infections, not with the antibiotics that kill off the good and the bad bacteria, but to use treatments that are very targeted and maybe more effective against the Pseudomonas than the conventional antibiotics, hopefully making patients feel better and reducing our reliance on antibiotics. So that's an update on the research. So we have new treatments coming, hopefully, for infection. But bronchiectasis is an inflammatory disease. And I've spoke the last time I spoke with Mary and Amy on one of these webinars about how important it is that we think about controlling the inflammation in our lungs, because that's what causes a lot of the damage. And so the big development in the last few years has been the arrival of specific anti-inflammatory treatments that target these neutrophils. Some of you will know that these cells are a very important part of your immune system. They're not something that you can live without. You need neutrophils to fight off infection. But as illustrated in this cartoon, when they pass into the lungs, they struggle to kill the infection. They cause these webs that patients cough up as sticky mucus, and they therefore increase the risk of chest infections and also increase symptoms. And so we need treatments that can stop all of that inflammation so that patients can feel better. And there is a new type of treatment called DPP-1 inhibitors. And so that's a mouthful, dipeptidyl peptidase 1 inhibitors. But they're a new type of drug, DPP-1 inhibitors, that stop this harmful inflammation in the lungs and have recently been tested in clinical trials. So they work in your bone marrow where the neutrophils are being born. So many of you will know your blood cells start their life in the bone marrow before they pass into the blood and eventually get into the lungs. So it's a long story. They start off in the bone marrow, they circulate in the blood, and then they go into the lungs. The drug works in the bone marrow, disabling these inflammatory components that cause damage to the lungs. And so the neutrophils can still get to the lungs, but they lack these damaging chemicals that cause the lungs to be inflamed and thereby hopefully reduce the amount of mucus and the risk of having an exacerbation. So there was a huge amount of discussion, particularly at the Paris meeting, about these new medicines, and particularly because it's been announced that the FDA in the United States is hopefully going to be rendering a decision on this, the approval of these medications. We hope in August. It's been announced in August. And that's really exciting because it means potentially, if it's approved, patients will be receiving these medications by the end of the year. Obviously, a lot of hurdles to go through before then, but that was certainly the talk of the town amongst the clinical community during this meeting. The reason that we're on the cusp, we hope, of an approval is that there is a positive trial of these medications in people with bronchiectasis. This is called the ASPEN study. It was announced last year, so some of you will have seen this data before. There's two doses of the medication, 25 milligrams and 10 milligrams. It's a once daily tablet, and it works, as I've just described, on the bone marrow to reduce the inflammation in the lungs. So people very kindly volunteered to either take one of the tablets or a placebo. Patients didn't know whether they were taking the real thing or the placebo for 1 year, and then reported whether they had chest infections, did questionnaires to tell us whether they had symptoms and what kind of symptoms they had, and they did lung function tests. And I'll show you the overview of the results here. The wonderful thing about this is that the trial included a very broad range of people with bronchiectasis, which means potentially these medicines could be a benefit to a lot of people. You had to have 2 or more exacerbations in the previous year, but it allowed people with bronchiectasis with lots of different causes. Patients who had active NTM, meaning they were being treated, were excluded, and people who had their bronchiectasis because they had COPD and asthma were also excluded, and people with CF were excluded. But apart from that, almost everybody else that I see in my clinics was allowed into the study. It was a huge trial, by far the largest one that's ever been conducted in bronchiectasis, with 1,767 patients randomized, which is amazing. Huge thank you, and I'll say this later as well, to everybody that contributed to this, because it's a huge global effort to do this, particularly as part of the study straddled the COVID-19 pandemic. And this was the result. It was a positive study. So there was a significant reduction of 20% in the frequency of exacerbations in both groups. Interestingly, the 10 milligram and the 25 milligram didn't seem to be very different, at least on the exacerbation endpoint. But you'll see later that the 25 milligrams seemed to be a bit better with some of the other things that we measured in the study. But this is really important because exacerbations are one of the most distressing things that patients experience when they have bronchiectasis. And this medication was consistently able to reduce the risk of having one of those exacerbations. One of the most important findings from the study was also that it slowed down the rate of decline in lung function. So bronchiectasis gets slowly worse over time. And you can see that from the lines here. This is a measure of how much the lung function has changed over the course of a year. So this is going down. And you can see that people who are on placebo declined by about 60 milliliters. That doesn't sound like a lot, but over many, many years, declining by 60 milliliters every year will mean that your lung function gradually gets worse, and that can translate into symptoms like breathlessness. And so it's important that we stop that from happening. And you can see that in the 25 milligram group, although they declined for the first 16 weeks, they stopped declining after that, resulting in a significant difference in lung function decline by week 52. And if that continues beyond 1 year, that could translate into a better long-term prognosis for these patients, which is why I'm really encouraged by these results. And the last thing that people want to know is this going to make us feel better? And what you can see from this graph, this is results of a questionnaire. The line going up means that patients were feeling better. And you can see that the solid blue, the solid purple line, which is the 25 milligram group, is the highest, meaning that symptoms were better in the 25 milligram group. And again, there was a significant difference between the 25 milligram group and the placebo group. Because of a variety of things related to how we do the analysis, we say that this is nominally significant because some of the other things that we measured were not significant prior to getting to this one. But if you ask me the question, is this medication going to make people feel better? The answer to that question is yes, particularly for the 25 milligram dose. And then the safety looks very good. So in terms of side effects, these numbers can seem quite high because we report during trials everything that patients feel during the study. But the important thing to say is that the people who got a placebo tablet had the same number of things that they reported, be that cough or headache or other types of side effects over a year, compared to people who got the brensocatib tablets. So the frequency of side effects, if we call them side effects, is the same whether you take a fake placebo tablet as if you take one of these medications, which is not to say it doesn't have side effects. Everything has side effects, but it's very, very similar to not taking a medication at all. The main side effect that we saw was some thickening of the skin called hyperkeratosis. Happened in a tiny number of people. The largest was 17 out of 500 people in the 25 milligram group. That's not likely to result in people needing to stop the medicine or being a distressing side effect. And most people who experienced this in the trial carried on in the trial and it didn't bother them enough to stop taking the medication, which is great. So that's the Aspen story, and it's a massive breakthrough for people with bronchiectasis. And when this becomes available, and I really fingers crossed that it does get regulatory approval at the mid to the end of this year, I think it's going to help a lot of people, and it'll be the first approved medication for bronchiectasis. Again, all of our fingers crossed that that's what's going to happen. It's not the only drug in this class, and so some new data that was discussed at the conference is some data. This is from China, actually. It's another drug in this class. It's the same mechanism, so it works on the neutrophils again as an anti-inflammatory. And in this study, which was a phase 2, which is the step before we get to the point at which we try and get a medication approved for use, there was up to a 60% reduction in the frequency of exacerbations in people in China. And so this is really encouraging because this is now going to be taken forward into a global trial. And that would be good because we need more anti-inflammatory medicines and as much new science as we can possibly get in people with bronchiectasis. So more good news. I remember giving these talks years ago where we were always a little bit negative because studies weren't working. And now every time I speak, there's a new positive study, which is all good for our patients, that new things are coming. This is a bit of scientific data that was presented at the conferences and has just been published online. And I wanted to mention it because it shows something I think that's quite important, even if it's a little bit complex. The anti-inflammatory medications are targeting a specific bit of the neutrophils. So they try and reduce the amount of inflammation that these neutrophils cause. And a question I often get from patients is, okay, but if it reduces the neutrophils, if it reduces the inflammation, is that going to have any impact on my infection because I've got Pseudomonas or I've got Haemophilus or I've got NTM? And is it going to have any impact on the mucus that I cough up? Because that's because of airway clearance and problems with mucus. And my answer I always say is it should help all of those things because those things are linked in this vicious cycle that we talk about. So this study that I'm showing you is evidence of that. So in this study, patients were given the two medications, brensocatib, 25 milligrams or 10 milligrams or placebo, and sputum samples have been taken to look for markers of mucus, markers of inflammation, and also the body's natural response against infection. And what these graphs are showing is that inflammation goes down. This is a particular type of neutrophil inflammation. We already knew that. But mucus goes down. So MUC5AC is the main mucus in the lungs. So this probably explains why our patients are saying that they feel better in the trial because the mucus is going down. And so this would be expected to translate into less phlegm coming up when you take the anti-inflammatory medicines. And then these graphs where things are going up, this is your body's response against infection. So if you take away the inflammation, it looks like the body is able to fight infections more effectively through these things. These are natural antibiotics that the body makes. So this data generated a lot of discussions at the conference because it's suggesting that anti-inflammatories are not just anti-inflammatory. They also help with mucus and they also help to fight infections, which is really exciting. Or as we put here, broad immunomodulatory properties with this new medication called brensocatib. So this is a bit of a complex scientific diagram. At the conference, we called this a confusogram, but I think we can make sense of it. If we put inflammation in the center, and bronchiectasis is an inflammatory problem, but there's linking lines with the mucus that people cough up. That's the mucus coming out of the the cells here and the fight against infection. If you take care of the middle bit, you also hit the two bits at the side as well. And so let's hope that we see that when these medications start to be used in clinic, and we see that people maybe need less antibiotics and also feel better from a symptom point of view. So in the last few minutes, I want to mention a couple of other things that are coming, because the other thing that was obvious from these conferences is that there's lots of new treatments coming for people with bronchiectasis being tested in clinical trials. You don't need to know all the names that are on here. I'm not going to talk you through all of the different medications, but this is a listing of all of the different targets and medications that are now being tested in people with bronchiectasis. One that I highlighted because it was discussed a bit at the conference is an injection, which is called anti-IL-33 antibodies. They're anti-inflammatories. When a virus attacks the lung, and we think a lot of exacerbations are caused by viruses, something called IL-33, a chemical, is released into the lungs, and this causes a lot of inflammation. If you were to block that, the idea is that if you block it, the inflammation doesn't happen, and the body deals with the virus without having this big inflammatory response caused by all these different cells, and so you don't get so many exacerbations. And this is now being tested in people with bronchiectasis, and is expected to give results within the next couple of years. Interestingly, there's also an effect of these of IL-33, this chemical that the lung makes, on the mucus glands, making it make more mucus. And so it's also possible that these new anti-inflammatory medicines could also have a symptom effect. So it's exciting to see that people are trying new things that could be beneficial for people with bronchiectasis. But I don't have any results to show you of this, just the fact that people are now trying. And the other one I'll mention is PDE3 and PDE4 inhibitors. So there's a drug that's used in COPD now called ensifentrine, and it's anti-inflammatory. So it helps to reduce inflammation, also helps the mucus cells to get rid of mucus from the lungs, and it reduces chest infections in people who've got COPD. And a trial of this in bronchiectasis has just kicked off. And so that's also really nice to see that people are trying to take what we've learned in other diseases and use them in people with bronchiectasis. So I think I'm right on time. I said I would talk for 45 minutes, and we're approximately 44 minutes. So I've got a couple of minutes to talk about the other important thing that was discussed at the conference, and that's about what care should look like. So many of you will know bronchiectasis has always been the poor relation. It's been a neglected disease, a Cinderella disease, it's sometimes referred to. In different countries, the level of care can be different. Some people are in specialist bronchiectasis clinics. Some people are looked after by pulmonologists. Some people are looked after by general practitioners. And it's a bit inconsistent depending on which country you live in. The best example of care for people with bronchiectasis is cystic fibrosis. This is an inherited disease where patients are dealt with in specialist clinics, and they have access to really good physiotherapy, medication access with a lot of licensed treatments that are reimbursed, dietitians, psychologists, microbiologists. And so there's a lot of debate about whether or not the model of care for CF could also be adapted to people with bronchiectasis. The problem is that there's about 40,000 people with CF in the US, and there may be as many as 500,000 to 1 million people with bronchiectasis. I've taken those numbers from my own estimates rather than what's reported, because I think the reporting, I think bronchiectasis is underreported in the US. And so we actually have a big healthcare challenge on our hands. I think we have a lot of patients who have a lot of needs, and it's important that we find ways of providing the best quality care, because people with bronchiectasis of all causes deserve high quality care. They deserve access to the medications that can stop the condition from getting worse. They deserve access to airway clearance, which is fundamental to living a healthy life with bronchiectasis. And that, unfortunately, is still patchy across the world. And so I think the future is the setting up of specialist clinics like we have in CF. The model will be different because the numbers of patients are larger, but it means getting patients to see clinicians who have experience of managing this disease, who know how to use these new medications appropriately, who do the right treatments, which means things like airway clearance, regular sputum samples to look for infection. All of these things are going to be very, very important. And so we'll be launching towards the end of this year a consultation on standards of care for people with bronchiectasis. This was something that was discussed at the Paris conference, which will define what each person with bronchiectasis should be able to expect from their doctor, and what good bronchiectasis care looks like, essentially. And that will hopefully help to set the framework for people getting more access to good quality care and physicians who know how to manage the condition. Because this is a really common disease and healthcare systems need to know how to manage it. So I think if I summarize these two conferences, again, big thank you to Mary and Amy for giving me the chance to talk about all of this science. Amazing new data on inflammation. So we need to think about how, from a patient perspective, how we keep our lungs healthy, which means reducing the amount of inflammation in our lungs. It's not just about medication. It's also about things like exercise, diet, airway clearance, etc. So treatment isn't just about putting up with symptoms, but also trying to control it so that the long-term outcome of the disease is better. And my main message, I think, coming out of this presentation is the hope for the future. There's never been more bronchiectasis research. There's more trials reported last year than had been reported in the previous 10 years. I mean, the amount of new information that's coming in bronchiectasis is really great to see, and means that we really do have hope that maybe we'll get the first licensed treatment at the end of this year, but following that, round the corner, maybe several licensed new treatments that will make a difference. I want to say a big thank you, as I said earlier, to Mary and Amy, who've driven a lot of the patient power in this disease. We're only getting all of this attention because the patient voice has said that we need it, and it's fabulous to see. And thank you to all the patients who've participated in research, because we wouldn't have these new treatments without research, and research depends on patients giving up their time to work with us. So big thank you. And I would finish by saying thank you to my team in Dundee who do all of the hard work, some of which I've shown today, and our partners that fund some of that research. And with that, I would be delighted to answer any questions that you have.
Great. Thank you so much, Dr. Chalmers. We have lots of questions coming in, and
I
just want to
30 questions already. That's fabulous.
Yeah. And I just want to remind people to put your questions in the question and answer. And also, Professor Chalmers cannot give personal medical advice. So I am going to start with a question that somebody sent me before the webinar. So this person is from New Zealand, and they're asking where the 3 sites in New Zealand were that participated in the Encore Promise studies, and will those sites be used again for future clinical research? And are those sites, do they have departments that treat NTM and bronchiectasis? So I'm not sure if you're familiar with those particular sites.
So unfortunately, I'm not. So there are centres in New Zealand that do a lot of bronchiectasis. I had a quick look. I'm just looking now actually to see if I can find the names of the sites, but I don't think they're listed in the paper that I've got. So unfortunately, I don't think I can help with that one. Okay. In terms of finding those specific sites, there are a number of centres in New Zealand that are very, very good. And in particular, there's one physician in New Zealand, Conroy Wong in Auckland, who's done a lot of research and runs a clinic for people with bronchiectasis. He did the original study of azithromycin, which we all now use every day. So there are very well established bronchiectasis centres and experts in New Zealand. If the purpose of the question is to find some experts in New Zealand that can help.
Okay, great. And I'm going to ask one other submitted question beforehand, and then Amy will ask a few from the Q&A. So this one has to do with artificial intelligence and how can AI help bronchiectasis?
Great question. So I think the easy answer to that question is we don't fully know yet because we're not currently using AI in our day-to-day practice. But I would say a couple of things. Firstly, from a patient perspective, we've recently looked at the sort of information that you can get by asking AI chat, things like ChatGPT, questions about your bronchiectasis. And it actually provides pretty good educational information. So if you've got questions about your bronchiectasis, rather than doing a Google search, which may find various things, if you ask ChatGPT, it's not as good as speaking to your doctor, of course, but AI does seem to be able to provide you with useful information. I say useful information rather than medical advice because you should always obviously get your medical advice from a medical practitioner. Where I see the first bit of AI making a difference for people with bronchiectasis is in imaging. So as you know, when you get a CAT scan, the doctor looks at the CAT scan and gives you a bit of feedback about what's on the scan. AI is now increasingly being applied to those scans to give much more detailed information and to standardize the interpretation between different doctors. And I can see in the next few years, you'll get your scan and the first thing you'll get is a report from AI telling you what it shows. And that may make it faster for us to diagnose things, but also more reliable. So I think AI is going to make a big difference, but it's not influencing things yet, at least not in my hospital.
Yeah, one of the things when I saw the question, I was wondering about, since I have primary ciliary dyskinesia, whether that might speed up the PCD diagnosis. If somebody, has an X-ray or CT scan showing bronchiectasis and has past history, that would lead to that and help connect it.
Yes, so I agree. We've actually got a project running at the moment, which is about it's called Be Alerted, and it's looking at healthcare records to see if we can find patients with bronchiectasis earlier using AI. So it's a research project at the moment, but it's sort of looking at, if you look at somebody's medical record and they're having chest infections every couple of years, can the AI detect patterns in the data that look like a person who's got bronchiectasis? And to your point about PCD, we know there's certain risk factors for PCD, like having severe rhinitis or having problems in early life. AI may be able to scan the medical record and flag to the doctor, this person's got some features that may suggest PCD. So I think in the future, it may well be something that helps with the diagnosis of these sorts of things.
All right, so we have over 50 questions in the chat. So I'm going to start off. There is one question that I saw that I think I'd like to address first because I've seen this come up and I want to clarify. So somebody's saying that they read today that brensocatib is delayed by the FDA and what's the impact. So I want to just clarify, it actually is not delayed. So just to quickly explain, when a new drug application is submitted, the FDA at some point sets a date. It's called a PDUFA date. And that's the date by which the FDA will give an answer as to whether, the drug is going to, be approved. There are times where the FDA will convene what's called an advisory committee or an AdCom. And those are external experts who function as sort of special employees of the FDA, and they are brought in to form these committees. And they go through a meeting. It's usually at least 6 hours, if not a full day. And they go through all of the data and they go through all of the studies that have already been published and they talk about everything. And then there are specific questions that the committee is asked and they answer those questions. And based on that, the committee makes a recommendation to the FDA on approval. That is what happened with ARIKAYCE, and it got approved. There are times where the FDA does not convene an advisory committee, and generally speaking, when they proceed without an AdCom, it means that the agency has reviewed the submitted data and they've determined that they have enough information to make a decision on the drug's approval without needing additional input from external experts or on an advisory committee. One of the factors that can determine whether or not they convene a meeting is the strength of the data. So if the clinical trials are well designed and show clear benefits with no major safety concerns, the FDA may actually say, we don't need a committee on this. And that's pretty much where we're at now with brensocatib. The PDUFA date is August 12th. That has not changed.
Yeah. And it was announced 3 days ago that they didn't need an advisory committee, I think.
Correct.
So I would take that as very positive.
It was not unexpected, that announcement either. So we were pretty happy. I've been through an advisory committee meeting. I'm kind of glad I don't have to go through one again right now.
Likewise, having gone through that pain myself as well.
Yeah, it was not fun, but we got through it. Let's kick it off. We have somebody who is asking about non-CF and being colonized with Burkholderia cepacia. Have you treated anybody like that? I guess would you treat them if they were colonized?
So I have. So I will tell you, every patient that I've ever seen with non-CF in inverted commas who's got Burkholderia cepacia has turned out to have cystic fibrosis. So in that situation, the patient in question should be tested at an expert center to make sure that they don't have cystic fibrosis. It's exceptionally rare to have that bug in people who don't have CF. Having said that, it can happen. And in that situation, there are specific treatments, specific antibiotics that we use for Burkholderia based on the guidelines for CF. But I think in that situation, because there's now modulator therapy for CF, it's so important that there's proper testing for those patients for CF.
Okay, good. We have somebody who has bronchiectasis. They nebulize with 7% sodium chloride, and they say they get short of breath after nebulizing. They then nebulize with Toby after that, and then 20 minutes on the vest, and they say they're getting short of breath. And then they ask about substituting Caistin for Toby.
Yeah. Okay. So great question. This is a common problem. Obviously, I can't provide direct advice to you, but what I can say is about 20% of people who take nebulized sodium chloride will get bronchospasm, which is tightening of the chest, and you get shorter breath. What we do, or you feel chest tightness, chest pain, we generally ask people to take a bronchodilator like salbutamol, I think it's called albuterol in the US, prior to taking the nebulizer, because that might just stop that from happening. If the symptoms don't settle with taking the bronchodilator, reducing the concentration of the salt to 3% or 6% might make the problem go away. But even with all of that, there are just some people where it's just so irritant to the lungs that we have to try a different medication. So what you're experiencing is a very common problem, and there are ways to manage it.
Okay, we have an interesting question here about saline nebulizing. Does saline nebulizer therapy have a cumulative effect over time, or is it only short term for like a few hours?
So yeah, it's sort of medium term between what you're describing. So it works immediately in that the high concentration of salt kind of acts as an irritant. The airway makes you cough. So patients will often report that they cough up stuff straight after their saline nebulizer. But it also sits in the airway for a few hours, drawing water into the airway through osmosis. That's why we use the high concentration of salt. And that helps to speed up the clearance of mucus. But it's given twice a day because it doesn't last for a long time. So it only lasts for a few hours.
Okay. All right. Okay. Do you have any thoughts on phage therapy to control Pseudomonas aeruginosa infection?
Yeah, so I think at the moment it's very much a research thing. So I presented to you today the press release, the preliminary data on the first phage trial. That's encouraging, but it's not something that's currently available for most people. And it's very unstandardized. Different hospitals do phages in slightly different ways, find the phages in slightly different ways. So I think at the moment, for those of us who are not working in clinical trials on phages, we're still using antibiotics. I think in 2 or 3 years, looking at these trials, it's possible that phages might be another thing that's available for our patients, which would be great.
Okay. So you mentioned in one of your first slides about there being a relationship between bronchiectasis and ulcerative colitis. And so the patient or this person's asking, why is there a relationship?
Yeah, great question. So many of the autoimmune diseases, so the diseases where the immune system doesn't work properly, cause bronchiectasis. So about 10% of ulcerative colitis patients will develop bronchiectasis. About 10% of rheumatoid arthritis patients will develop bronchiectasis. Many people with bronchiectasis have Sjogren's syndrome, which is a disease where the eyes and other secretions dry up. These are all problems with the immune system. Ulcerative colitis is very, very commonly associated with bronchiectasis. And the reason is, this is kind of cool, when your body is developing in the womb, yeah, the foregut, which is the ancestor of the lung, and the gut is the same. So the cells that divide into your lung and the cells that divide into your gut are essentially the same. And so the type of inflammation that can happen in the lung can also happen in the gut. Things that go wrong in the gut often go wrong in the lung. And that's why there's often a big link for patients. Patients will tell me that their gut health is linked to their lung health. And that's sort of most extremely demonstrated by the ulcerative colitis, where you get exactly the same ulceration and damage in the lungs as you do in the gut. Interesting.
I was surprised with when I was researching bronchiectasis and the causes and all the different things that can cause bronchiectasis.
So there's more than 100 conditions have been associated with bronchiectasis. The first question I always teach that the first question a doctor has to ask themselves when they see a patient is, why has my patient got bronchiectasis? Which of those underlying conditions does my patient have? And it's a very, very important thing, because the treatment changes depending on what the cause is.
Yeah. So the next question is actually related. They're asking, in PCD, the sinuses and sometimes the ears are often infected by Pseudomonas. So they're asking, does inhaled antibiotics make sense versus IV antibiotics?
Yeah,
And
good
maybe you could
question.
talk about the pros and cons between those and the situations.
Yeah, good question. So, and I get this question a lot from patients. So some patients feel as if the inhaled antibiotics, if they breathe through their nose, also affect the sinuses rather than only affecting the lungs, but they're not designed to do it that way. So if you've got sinusitis symptoms or features of active inflammation of the sinuses, that needs to be treated separately. So that's often with oral or IV antibiotics. And then things like nasal douching in order to try and get clean out the nose and the sinuses for the chronic rhinosinusitis. Very common problem in PCD. So the inhaled antibiotics work well for the lungs, but the treatment for the nose is also very important.
Is it possible to administer 2 different antibody therapies at the same time? And they're mentioning in particular, and I'm going to butcher the name of this, dupilumab.
Perfect. You did it.
Okay. For nasal polyps and the antibody, I guess you mentioned preparation for Pseudomonas or bronchiectasis.
Yes, so there's absolutely no problem with giving more than one antibody at the same time. Your body at the moment has thousands, maybe hundreds of thousands of antibodies different types of antibodies running around inside it. And so antibodies are very safe and quite a natural treatment in the sense that bodies already contain lots of antibodies. So it's not uncommon now that somebody could be on more than one antibody treatment.
And I'm very interested in hearing the results of that study. I just want to mention to everybody that we are planning to have a webinar maybe late July or in August that will be a summary of the World Bronchiectasis Conference that is happening in Australia this year. So we'll definitely have to get more information about how that antibody study.
Yeah, no, I'm really looking forward to talking about it. I think it's exciting to think we might have some new treatments for Pseudomonas as well.
Yeah. The new treatments, is there one that is better with dealing with plugging?
Good question. So the anti-inflammatory treatments I showed you do reduce the levels of mucus, which is the thing that gets plugged in the airways. But I don't think they are intended to, and I don't think they are the main treatment that's going to be dealing with mucus plugging. So mucus plugging can be caused by different things. So if the mucus plugging is being driven a lot by infection, sometimes treatment with antibiotics is what's needed. If people have got very thick secretions, what we talked about earlier, hypertonic saline can be quite good for dealing with mucus plugging. But there's a number of new trials coming of also medications that target mucus specifically. And I think that's what the next thing that we need in this disease are treatments that specifically reduce the amount of mucus that's made, because mucus plugging is a big problem. So things are coming that are stronger and easier to take than hypertonic saline.
When do you think that these new medications will be available in Europe and specifically Portugal?
Yeah, great question. So the company have announced off the back of the August date for the US that the likely availability date in Europe and Japan is early next year. So I would like it as soon as possible for my patients, and so I hope that's right, and it's about a year from now, the beginning of 2026, that we're able to make these available in Europe and the UK and potentially Japan.
This person has a question that is sort of piggybacking on the, and this is another one that I'm not good at saying, the Burkholderia.
Oh, right, yes.
So they're asking if you have both of those, and this person, and they have severe bronchiectasis, they do have alpha 1. And you mentioned, that it's very rare to be in anything but CF. So they asked if you had any comments or thoughts about treating that.
Yeah, so there are specific antibiotics that we can give against Burkholderia, and some of those also work against Pseudomonas. So again, it's inhaled antibiotics, sometimes intravenous antibiotics. These are difficult bugs to manage. Burkholderia is quite resistant to a lot of the usual antibiotics. So it has to be guided by the results of microbiology tests. So we test a set of antibiotics in the lab against the bug and then find one that's active against both the Burkholderia and the Pseudomonas. Sometimes, thinking off the top of my head, levofloxacin, for example, may be active against both of them. Others may be active against both of them. So that's how we go about selecting the right treatment. But it's extremely challenging with Burkholderia because it's often resistant to many antibiotics.
And there's an additional comment. Your work and presentations are very helpful. Thank you.
Well, I'm delighted to hear that.
Okay, so the next one, based on the recent Johnson et al. Result, does that suggest there is a decreased need for airway clearance therapies and that pharmacotherapies will completely, sort of just jumped on me, sorry. Um,
No, you're okay. I think I saw
No,
the
I'm
question. So
fine.
the questions whether if we're taking brensocatib or other treatments, do we need to stop doing airway clearance? And unfortunately, I think the answer is no, because although these will reduce mucus, I think they're not going to take it away completely. And so I think patients are still going to need to do airway clearance. This is probably the most important treatment that we do is airway clearance, because that's what's wrong in a bronchiectasis lung, is the lack of clearance of things from the airways. So for the foreseeable future, I think none of these treatments will take away the need to keep doing that.
you, Amy?
Yeah, sure. I will take over some of these questions.
Thanks.
So there have been a couple of questions about the slide deck and a list about the clinical trials. So for the clinical trials, you can go to clinicaltrials.gov and do a search for bronchiectasis trials, but there were some listed in the slide deck, and somebody actually did ask if the slide deck from today would be made available. So I think we will find out from Dr. Chalmers about that, but you will also be able to see the slides when the video is made available. Did we do the question up here about chronic sinusitis already? There's one at the top. If we haven't done it, let's do that because that's a favorite of mine.
Go for it.
If you have MAC and bronchiectasis and chronic sinusitis with a history of sinus surgery, is it possible to have MAC in the sinuses as well? Also, could sinus rinses be a cause of MAC?
So could sinus rinses be a cause of MAC? Okay, that's a difficult question. I would say sinus disease is not my area of expertise. I mean, you can get NTM infection outside of the lungs in almost any part of the body, even in the skin, for example. So I'm sure it's possible to get MAC in the sinuses, but I have not seen many cases of MAC in the sinuses. And I don't know the answer about sinus rinses. Do you know, Amy?
Well, I don't know if it could be a cause of MAC in the sinuses, but I do know for sure you're supposed to use sterile water or at the very least distilled water.
Yeah. So I think it's very unlikely to be a problem.
Yeah, I don't hear that much about it.
Yeah, it's not something that I've seen, and I've seen a lot of patients with MAC in particular. It's not a common non-pulmonary manifestation of MAC.
We've had a couple of questions about phage therapy, one of which was, can they be used to target microorganisms? One of the things I do know about phages is that if you have a phage that targets, for example, Pseudomonas, it may not work on every strain of Pseudomonas. Well, that's one of the reasons phage therapy is so complicated right now, is you have to find a phage that works against a person's particular strain. And I know one of the things they're working on in phage research is finding ways to make sort of more universal strains. But somebody's asking, is phage therapy being investigated to treat mycobacterial infections like abscessus and avium?
Yes, absolutely. There's actually published case reports and case series now of mycobacterial infections, both abscessus and avium, particularly abscessus, which is obviously very difficult to treat, where phages have been successfully used. Exactly as you say, Amy, what's often being done in these situations is that people are going into water sources, even sewage and things like that, to find in water where there's lots and lots of infection, and within that you can harvest phages, and then they screen those phages to find ones that are active against the patient's particular mycobacterium. So it's a very, very involved process and very, very difficult. So not the kind of thing that you could do for thousands or hundreds of thousands of people, but it's used in situations where there's very few other treatment options, and it's reported to work, but it doesn't work for everybody. And then what you said is very important. In order to turn this into something that could be available for everybody, people are investigating in the lab, genetically engineering phages and things like that to make them more universal. And that's, I think, where this is going to go if it's going to be a more widespread therapy.
Yeah, and I do know that there are some people looking at using AI to help screen phage libraries and speed up that process. I want to mention we actually are planning a webinar on phage therapy later this year in August for World NTM Day. So you guys can stay tuned for that, and we will be putting out that information as well. So somebody's asking about your opinion. If brensocatib reduces inflammation in the lungs, would it reduce inflammation in other inflammatory diseases such as RA, lupus, etc.? I'm going to let you answer that one, but I do know that there is a clinical trial either recruiting or pending recruiting for brensocatib for sinusitis, chronic sinusitis, which is another inflammatory issue. So
You're correct. So so the answer to your question is yes, it's very likely to work in other diseases because it's given systemically, which means it doesn't just go in the lungs, it will reduce inflammation everywhere. So it's being tested right now in chronic rhinosinusitis without nasal polyps, which is a common problem. It's also being tested in a condition you might not have heard of called hidradenitis suppurativa, which is a skin condition caused by neutrophils. And there's many other diseases that people are looking at for these treatments because they may work against a lot of types of inflammation. Exciting times.
it is, and you were correct to point out the hidradenitis suppurativa is it's a very challenging disease that people live with, and it's very painful. And it's exciting to see that there are treatments actually being investigated for them. What therapies are now studied that will clear the plugged bronchi?
Yeah, so we talked about that a moment ago with Mary. So there are no sort of phase 3s at the moment of direct mucus acting drugs, but some of the anti-inflammatories that I mentioned might work against mucus. But for the time being, hypertonic saline's the main thing that we use, and hopefully better things will come in the future.
Okay, Mary, you want to take over for a bit?
Sure. Will people with bronchiectasis but no exacerbations be able to access the new treatments?
Great question. So at the moment, we don't know what the labels will say or what the regulatory authorities will say about approval. I don't know the answer to the question in terms of access. If we reframe the question a bit about will people with bronchiectasis with no exacerbations benefit from the treatment, I think some people will. So I think the inclusion criteria of the trials with brensocatib was 2 or more exacerbations. Some people with no exacerbations have really terrible symptoms and their lung function is getting worse over time. And it would be really interesting and important to test whether anti-inflammatory treatment works for those people as well. Because bronchiectasis is not just about exacerbations, and these treatments have benefits beyond exacerbations.
What happens to your body if you happen to swallow sputum with Pseudomonas when coughing?
Probably nothing. So don't worry about it. The most recent study that looked at the gut microbiome in people with bronchiectasis found that there are bugs that are different in people with Pseudomonas, but there isn't a big difference in the amount of Pseudomonas. So your body's just getting rid of it from the gut. So don't worry about it. It's not doing any harm in your gut as far as we can tell.
Great. How frequently should someone with bronchiectasis have monitoring sputum samples, or what is the recommendation? Are there guidelines on that?
Yeah. So my approach for my patients is to ask for it a minimum of once a year, but to do it more frequently if people have severe symptoms, lots of exacerbations, or other risk factors. We tell our patients that they should submit a sputum sample every time they have an exacerbation. So if you have 3 exacerbations a year, that's at least 3 sputum samples a year. And that's what the guidelines say. I think it does have to be personalized to the individual. And of course, some patients don't produce sputum. And so we need to find other ways of monitoring their lungs.
Can you discuss the challenge of using azithromycin as a long-term therapy in people that have had NTM infections in the past? so have been and probably will need to be treated with azithromycin in the future. Interested in the issue of azithromycin resistance that may develop.
Yes, thank you. So azithromycin is probably the most important medication when it comes to treating NTM. So your success of treating an NTM is much higher if the bug is sensitive to azithromycin. So the risk with using azithromycin for bronchiectasis without NTM is if you treat NTM with azithromycin by itself, it becomes resistant and it becomes very, very difficult to treat. So I'm afraid the answer to your question, at least for me, is I never use azithromycin in somebody who I think has NTM or who I think is at high risk of getting an NTM, which includes people who've had NTM in the past, because I'm just too scared to cause resistance. And so I use alternative treatments. So if somebody needs azithromycin but they can't take it, I would use a different oral antibiotic. I use quite a lot of long-term doxycycline, for example, that also has anti-inflammatory properties, and it's not needed for the NTM regimen. And then there's the inhaled antibiotics. So if somebody's got Pseudomonas, I would use a nebulized antibiotic rather than azithromycin. It's a really, really difficult thing. I mean, Amy in this audience doesn't need me to tell you, but NTM is a terrible, terrible thing to deal with. It makes regimens so complicated.
Yeah.
Mary, do you want me to take the next question about exercise and breathing?
Sure. I just want to kind of follow up with this. You know, and I think in one of our other webinars, Professor Chalmers, there was a question about if brensocatib or some of these inhibitors would, by reducing inflammation, reduce the need of using azithromycin in bronchiectasis.
So I think we don't know. I think certainly if somebody's got NTM and they need an anti-inflammatory treatment, I would use brensocatib in a heartbeat, or they've got a risk of NTM, I'd use brensocatib rather than azithromycin because there's going to be no risk of inducing resistance. So I think it will give us an alternative option for those patients who can't take azithromycin. But also, I think for many people who could take azithromycin, brensocatib may be a better option because of the lack of resistance issue for all bugs. People ideally don't want to be on antibiotics long term. I think we still haven't quite figured out exactly where brensocatib will fit in relation to azithromycin.
Okay, we have a couple of questions that actually are about this. And she says it's not necessarily in your purview, but do you know if any studies are being done on the impact of aerobic exercise, breathing or meditation practices like Qigong or yoga as quote unquote medication for those with bronchiectasis? I guess it would be more like an adjunct therapy. And I'm not sure if there are any studies being done, but I do know that a number of our patients do use practices like that. They do Pilates, they do yoga, they do Qigong, they find it helpful. Our official position is if you find something that works and helps you, that's great. As long as you do it safely, that's wonderful, and you should. We are firm believers in exercise as adjunct therapy, and I can tell you when my late stepmom was alive, the only time she was not on a treadmill or an exercise bike is when she had an exacerbation and was in the hospital. Those two conditions had to exist, or else she was exercising every day.
Yeah, so I fully endorse Amy's position. If you find it helpful, it's good for you. It's not going to do any harm. You should do it. And aerobic exercise, I tell every patient that I look after that they should take exercise if they can, because it definitely helps with airway clearance. And the only research I know about with this is evidence that people who do take regular exercise do have better quality of life and fewer exacerbations than people that don't. So that's not a randomized trial, but it's good enough for me.
Has there been any newer research or treatments for ABPA?
So yes and no. So it's hard to do trials in ABPA, but there is more data coming on the biologic drugs. So you may know ABPA, for anyone on the call who isn't familiar with it, is allergic bronchopulmonary aspergillosis. It's an allergy to a fungus in the environment called Aspergillus. It's usually treated with long-term steroid medications, which have a lot of side effects. Increasingly, doctors are using biologic medications that are used for severe asthma, and they seem to work quite well for this disease. So some doctors are now using them up front. Some are using them if the steroids haven't controlled things after a few weeks or a few months. So there are, I think, better treatments for ABPA coming. But it's a bit like NTM is ABPA. It's another one of these very tricky, difficult things to do where the treatment has to be quite personalized to the individual.
We are at the 2:30 mark. So Dr. Chalmers, you let us know how much longer you can continue because we still have a lot of open questions.
Yeah, I'm happy to keep going.
Okay. Great.
I never stop enjoying talking to patients, so we just keep on going as long as you're happy to have me.
Great. So somebody has a question about the concerns about use of inhaled amikacin and or clofazimine, and they are asking, is kidney damage reversible, and are there any alternative viable treatments for MAC abscessus and minor cavitary disease?
Yeah, so this is obviously very, very difficult to answer. So in general, inhaled amikacin, liposomal amikacin has some adverse effects, most commonly dysphonia, difficulty with the voice, but the trials have shown that it's generally very safe. Clofazimine also has side effects, but many patients will tolerate it. Kidney damage can be reversible, but in some cases it's not. So it's not really possible to give you a definite yes or no answer with that. And in terms of other treatments for Mycobacterium abscessus, there are a very large number of antibiotics that can be used for Mycobacterium abscessus. It's guided by what the bacteria is resistant to and what's it sensitive to, and what we can put into a combination, because you always have to give multiple drugs for abscessus, and so we have to balance the combinations of drugs by their side effects. So there are a variety of antibiotic treatments for abscessus, but it can't be answered without sort of more information about what's been tried, what sort of side effects there's been, and what the bug is sensitive to. In terms of future treatments for Mycobacterium abscessus, one of them that's in development is phage. And let's hope there will be more, because it is a very, very tricky thing to treat.
Okay. Here's a very interesting question, and I think we probably all have something to contribute to this answer. How do we make patients part of the journey as a medical device company? And I think that's a wonderful question. Mary, I know you and I had an experience last fall with a medical device company that made a point of bringing several of us out to their company meeting so that we could talk to their entire company about patient experiences. And they had several patients there as well, as in addition to the advocates. And that's not something I think we see as much as we see it in the pharmaceutical side. Do you have any thoughts about how we better engage the device companies? I know that, conferences like ours in May are helpful because we actually have them at the conference. They get to meet patients, they get to talk to them, one-on-one. But I don't know if there are other ideas that either you or Dr. Chalmers have.
I mean, for me, it would be reaching out to the patient advocacy groups. If you're looking to talk, if you want input from NTM patients, I would, go to NTMIR, or COPD Foundation and bronchiectasis, or COPD oriented COPD Foundation, running on air, we're working with oxygen. So, reaching out to the different patient groups that do related, are related to the area that the devices would be. And, if it's a bronchiectasis oriented device, then, there's lots of different patient organizations, and, most of us are connected and, can reach out also. But yeah, that would be my suggestion.
Yeah, I think Mary just made a really good point. I think a lot of people are not aware of just how much some of our organizations are connected to each other and how often we talk to each other and collaborate with each other. So I think, if you're a company and you're looking to collaborate more with patients, reaching out to us and asking, to connect with others as well. I think that's a really good way to do it.
Yeah,
Um,
I can only endorse that and say, we shouldn't be designing anything in terms of the care pathway for people with bronchiectasis without involving patients. All of the trials that I've talked about today have, had patients involved from the beginning to the very end. And it's absolutely critical that we do that.
Yeah, this actually reminds me of a story. Like, this is something that happened when Arikayce was in the process of going through clinical trials and then coming to market. And one of them, it wasn't a clinical trial, but it was a market research study, and it was on packaging. And somebody said, why are they wasting time and money on this? And my response was, some patients actually have neuropathy. And so they need to make sure that patients can actually open their medication and get it out of the package. That's the kind of attention to detail that you can only think about if you are regularly talking to and meeting with patients, because you have to really learn about the full spectrum of the patient journey before those kinds of details are going to jump out at you. But that was a really interesting one, and I think it makes a huge difference in terms of how the patient views the company as somebody, as an advocate for them, as a company that is working on their behalf. Those little details that they pay attention to really just make a huge difference. We have somebody who had asked a question about quality of patient care. You were I guess you had mentioned something about there were going to be consultations about quality of patient care, and I don't know if that applied with the NHS in the UK generally.
Yeah, so there's going to be new guidelines both in the US and Europe likely coming out this year from CHEST and the ERS. So coming out of that, I hope we'll get standards of care, which are sort of statements about what kind of care patients should expect, and that will then feed into centers generally providing better care for patients. In the US, the Care Center Network has now been established, which hopefully will also help to drive up the quality of care that patients expect. So there are now initiatives that are looking at making the patient experience better within healthcare, which I think is critical.
Yeah. So here's an interesting one. If inflammation is a big issue and a high percentage of bronchiectasis patients are postmenopausal women, are there any studies exploring hormone replacement?
The answer to it are there any studies exploring hormone replacement? The answer is no. Is it an interesting question? Yes, it's a really interesting question, because we know people with NTM and bronchiectasis, 60 to 70% are women. There's something in there about female hormones, and it seems to come on in many people, or at least worsen in many people around the time of the menopause. So I think it's a neglected area that needs to be studied much more.
Okay, next question. Thank you for your excellent presentation. My question is a little different. It is regarding hemoptysis. Is there a medication to stop that?
Yeah, great question. Is there the simple answer to the question is no, there's not one single medication that's perfect to stop hemoptysis, I'm afraid. We as doctors need to investigate why you're having hemoptysis. Sometimes it means that you're having recurrent chest infections because the infection causes the airway wall to become weaker and the blood to come out. Sometimes we can stop other medications like blood thinners, and that can stop the hemoptysis. In some cases, there are medications that are used. Tranexamic acid that's used for bleeding in other places can occasionally be used for bronchiectasis, but it has some risks associated with it. And finally, there is not medication, but in hemoptysis that's very severe or persistent, there are radiological procedures that can be used to block aberrant arteries and stop these things from happening. It's called bronchial artery embolization. So there are treatments that you should discuss with your doctor, but it isn't a simple thing. But in most people, just good management of the inflammation in the lungs can stop it.
And that actually leads to a couple of other questions that people have asked about brensocatib. So as I understand it, brensocatib if you have hemoptysis, it's not necessarily an eliminating factor to taking it.
Not as far as I know. I
Right,
don't.
it actually might
I,
help because you're
yeah,
not
yeah.
going to have to.
I don't see any reason why that would be a disqualifying factor, and reducing inflammation in the lungs might reduce hemoptysis. Although I don't think we have specific data on that.
What if somebody actually isn't really having exacerbations, but they do have bronchiectasis? Would they, be a candidate?
I don't know what the label is going to say in the US or Europe. I suspect it will follow what the trials have included,
Yeah.
which is people with a history of exacerbations.
Yeah.
If you ask me if people are likely to benefit, I think people who've got a lot of symptoms or whose lung function is getting worse may well benefit, because we showed in the trials that it slows down decline in lung function and improves symptoms. So I hope either we'll get the opportunity to use it for some patients that are really struggling, or if necessary, we do trials in that group that doesn't have exacerbations and prove that it works.
And patients who have NTM are also eligible to take brensocatib, correct?
So the patients with active NTM were excluded from the trial. So that means people NTM who are taking NTM treatment at the time.
Okay.
So whether that will end up being an exclusion from the label or in guidelines, I guess we'll have to see. But if patients have got a history of NTM and they've now got NTM associated bronchiectasis and they fulfill the other criteria, there's no reason why they shouldn't be eligible for NTM. For brensocatib.
Okay. Mary, do you want to take a few questions now?
Sure. There's one question here that I see, where are the trial sites in the US? When we send out the video, the link for the video, I'll include the where you can go to check on trials in the US and to see if there are any near you, and who to contact to get more information. All right. Could you comment how flu virus infection affect bronchiectasis?
Sure. So influenza is one of the most common causes of exacerbation in people with bronchiectasis. So about 50 to 60% of exacerbations in bronchiectasis are caused by viruses. And flu is probably the second most common after the common cold virus for causing exacerbations. Everyone on the call, please get your flu vaccine, because it will potentially stop you from having a nasty exacerbation. Flu is very nasty for people with bronchiectasis because it flares up the already present inflammation in the lungs.
How do you see the role of devices and drugs in the new and evolving landscape of bronchiectasis?
Yeah, so I think there's an ongoing need for both our existing devices and drugs and for new devices and drugs going forward. I think let's hope brensocatib gets approved. I have to keep on knocking wood, because until it's signed off, I can't take anything for granted, but let's assuming it's approved. It's going to make a really big difference, but it's not going to be the last thing that we need for people with bronchiectasis. There's still going to be a big need there. So we still need better devices for airway clearance, for delivering drugs, and we still need new anti-inflammatory drugs, new antibiotics, and things that target mucus. So I think what we've shown with brensocatib is that we can do this. We've got a really active patient population that's engaged in research, and we're able to show that things work because we understand the disease and its biology. So I'm hoping lots of people will come in and develop their new devices or their new drugs in bronchiectasis.
There's a question, was there anything new for NTM at the conference?
Yeah, great question. So there have been a couple of new trials in NTM. We're sort of waiting for results of some of them. So the ARISE study, which is a trial of liposomal amikacin as an upfront treatment for MAC, has recently been reported. I don't think it's been published yet, but it's Chuck Daly showed that data at the conference, and that showed better microbiological response and better quality of life symptoms in people that got upfront treatment with liposomal amikacin plus 2 drugs compared to 2 drugs. So that's really encouraging data. There's a second trial called Encore that's going to do the same again, but in a larger cohort of patients. And I guess will give us the definitive answer as to whether we should be giving the inhaled antibiotic amikacin as an upfront treatment for patients with MAC. So that's encouraging, and that's some new data for NTM, but really waiting for that bigger trial. There was a couple of other studies that were presented, including a monotherapy trial, an early monotherapy trial for people with Mycobacterium abscessus. So a little bit of new news for NTM, but we definitely need more.
And I just want to mention again and those interested in NTM research in particular, but also bronchiectasis, that there is the conference in May. And when we send out the email, we'll send that again also. Or maybe you'll send out an email tomorrow or Monday, actually, that has some of this precursor info, just so you have it ahead of time. But that'll have a lot more information about NTM, and that one is in person and also virtual. All right, and so I'm going to ask one, maybe 2 more questions, and then we're going to call it a webinar. We've got a lot of questions still, and there's no way, you're going to have to take off work tomorrow if we're going to continue with all of these. So we will work on getting the questions answered, maybe offline.
I'm very happy, Mary, to answer all the questions in an email document or something and get them sent round everybody, because I think if people have taken the time to ask a question, I should try and give them an answer.
Sure. Okay, great. So we'll get those. I'll get those to you, and when we send out the webinar link, we hopefully maybe then we can include your responses too. Okay. So one more question. What, if any, of the new treatment developments might be relevant for common variable immunodeficiency and low immunoglobulin M?
So good question. So most of the studies that we've done so far have excluded people with immune deficiencies like common variable immune deficiency. And that's because people have been worried that anti-inflammatory treatments might increase infections in people with these things. So at the moment, I think that group of patients may be excluded from getting drugs like brensocatib. I would like to see trials in that group in order to try and make them more broadly available, because I suspect they will work, and I suspect that there won't be an infection problem. So some of the new treatments that are coming may well allow CVID patients to participate in the trials. But my assumption is that brensocatib will not be available for that group because they weren't included in the trials.
I am going to ask just one more. The graph on brensocatib seemed to show some of the positive effects decreasing over time. Would patients have the drug for a certain period of time or long term?
Yeah, so that's a really good question. So the way I would say that is that you do get certainly with the symptoms, you get a big improvement at the beginning, and then it sort of plateaus, meaning that once you've got the improvement, you've improved. That's a really good thing. It means you've got a sustained improvement. If you feel good and you stay feeling good, that's a good thing. So I think as soon as you stop taking the medications, you're likely to go down again. You're likely to feel less well, and your lung function will start declining. We know that because of the biomarker data, the sputum data that we've looked at, that when you stop taking the drug, the inflammation does come back. So I think it's going to be a long-term treatment that people have to take all the time, rather than something that you go on to and then stop taking. But my interpretation of the data would be that the benefit's going to be sustained over the long term.
Thank you so much, Professor Chalmers. As always, love having you presenting for us. Um, always learn a lot. So, and appreciate all the work that you're doing with bronchiectasis to help us have these treatments eventually.
Well, likewise. Thank you, Mary and Amy. Really lovely to work with you, and thank you to all of the audience for staying longer and asking so many questions. It's because we have such an amazing patient population that all of the progress is being made. So thank you.
Thank you so much, Dr. Chalmers.
And thank you, everybody, for attending today. We'll see you on our next webinar.
Bye-bye.
Bye.